Hello, everybody. Today, Ashley and I will be discussing fetal alcohol syndrome. We will be discussing this diagnosis within the elementary school setting in the intervention area of behavior management.
FAS results from intrauterine exposure to alcohol, where the mother ingests alcohol while pregnant. FAS is a diagnosis that falls on the fetal alcohol spectrum, which is a blanket term that includes those who are affected by prenatal alcohol exposure. It affects 33.5 per 1,000 children, and it is noted that this diagnosis is commonly missed or misdiagnosed, preventing affected children from receiving needed services in a timely fashion.
Children with FAS are susceptible for many body structure impairments. They can have prenatal and/or postnatal growth retardation, which means they are in the 10th percentile or less for their growth, including weight and height. They have abnormal facial features, including a flat nasal bridge, smooth ridge between the nose and upper lip, thin upper lip, and an upturned nose. The central nervous system also has dysfunctions such as decreased brain growth, abnormal structure, and abnormal neurophysiology. They have septal defects that affect their cardiac functions and kidney problems that affect their endocrine functions as well.
Body function impairments for children with FAS can include mental, sensory, and neuromuscular deficits. Children with FAS have cognitive impairments that may include intellectual disabilities, learning disabilities, problems following directions, difficulty understanding the consequences of their actions, poor memory skills, inattentiveness, poor executive functioning, and poor reasoning skills. They are context-specific learners, so what is learned in one context will not apply to another situation. The child may also experience visual perceptual deficits, including low visual acuity or decreased visual motor integration. The child may also experience neurosensory hearing loss, as well as have tactile sensitivity to different food textures or articles of clothing. It is usual for a child with FAS to have low muscle tone as well as reflex changes and limb and gait ataxia.
This diagnosis also affects the activity limitations of the child. They tend to have decreased fine motor skills, including deficits in manual coordination. They have disorders of behavioral regulation such as hyperactivity, poor impulse control, aggression, and inappropriate behavior, which causes them to break rules and be considered a troublemaker. They also have difficulty regulating their emotions and tend to have tantrums that involve explosive anger and frustration. They may not be able to regulate their anxiety, causing them to have anxious behaviors such as gnawing on pencils or pulling out hair.
Participation of children with FAS can be impaired in many aspects. The child may tend to have difficulty learning to perform ADLs and IADLs, such as feeding with poor oral motor control or dressing due to tactile sensitivity. Children tend to have sleep disturbances, with insomnia being the most frequent, followed by diminished sleep efficiency. They often struggle in school due to poor concentration, following classroom rules, behavior regulation, and poor handwriting skills that are due to muscle weakness, fine motor dysfunction, and difficulty monitoring force. They also are affected in school by their cognitive impairments and intellectual disabilities. Children tend to have difficulty with social participation due to difficulty adhering to social boundaries and rules, as well as their aggressive behavior. Their speech and language delays may also affect their social participation and difficulty in building peer relationships.
Occupational therapists work on helping clients become successful in their occupations. For children in elementary school, many of these occupations occur during school, such as education, play, and even some ADLs, such as feeding during lunch and dressing to go outside. And OTs have goals based on these occupational needs of the client in the school setting. Due to the clinical presentation, children with FAS have many deficits that interfere with the occupation of education. One of these deficits is sensory processing. Lack of ability to interpret and organize sensory information found with FAS can lead to poor adaptive behavior and challenges meeting expectations and achieving success at school. OTs also address behavior and emotional regulation that interferes with being able to participate in class to gain full knowledge potential as well as play and socialize with others due to the aggression and poor impulse control. Children are often referred to OT due to poor handwriting and challenges with fine motor, which is seen in many children with FAS with decreased fine motor skills as well as poor visual motor abilities.
One assessment that is appropriate to administer to a child with FAS is the Test of Handwriting Skills Revised, which measures the area of handwriting. This assesses a child's neurosensory integration skills, which are decreased in children with FAS, in either manuscript or cursive writing. Due to the clinical presentation of children with FAS having poor legibility, this assessment would be appropriate to use. Another assessment is the Bury Visual Motor Integration Test, which measures the area of visual perception. Specifically, it assesses difficulties in integrating or coordinating visual perception and motor abilities. Children with FAS often have visual acuity and visual motor deficits that affect their occupations in school. The third assessment is the Behavior Assessment System for Children, measuring the area of behavior management. This tool measures different aspects of behavior and personality, including social skills, aggression, and anxiety, which are issues that children with FAS typically present with, which affect the client's performance in school and in social situations.
The goal we have made for the intervention area of behavior management is in 6 weeks, the client will improve behavior management by decreasing the number of classroom disruptions that require teacher redirection to 4 times per day.
For data collection, the teacher will document on a chart as shown how many times per day the client disrupts the classroom that required their redirection. The teacher will have to fill out the date, the antecedent of the behavior, and the behavior shown. An example could be that the antecedent behavior was a group of students and the client doing a group craft, and the group of students wanted a different color than the client. Then the behavior displayed would be the client throwing the craft on the ground. As an OT, we can look at the chart, identify how many times a day the client displays disruptive behavior, and based on the behaviors, any adjustments to make in the intervention.
The PEO model focuses on how the client's occupational performance changes due to the person, environment, and occupation. Behavioral problems occur when any part of this 3-element model is not working properly and occupational performance is disrupted, since this model recognizes that a person's contexts are continually shifting, and as contexts change, the behavior necessary to accomplish a goal also changes. Supporting the client's abilities, the classroom environment, and the classroom tasks through intervention and modifications will help to improve the client's overall occupational performance.
3 treatment activities we are going to outline are the ALERT program, How Does Your Engine Run?, classroom modifications, and social stories.
One treatment idea we could utilize for children with FAS is the ALERT program, How Does Your Engine Run? This program helps children understand their states of arousal by using the analogy of engine speeds being low, high, or just right through corresponding activities. This helps the client with self-regulation as well due to the child exploring methods to change speeds and learning when it is appropriate to do so. For a child with FAS, the child may learn to recognize when they are at a heightened state and then use their learned methods to calm themselves. Therefore, this is a remedial intervention that is component-based.
Another intervention strategy is modifying the classroom environment. Classroom environments can facilitate the client's ability to regulate their behaviors and emotions appropriately if distractions are disrupting the client's attentiveness and ability to learn. Modifications to the environment could include minimal visual and auditory distractions, clearly designated activity centers, use of daily schedules that are easily visible, clearly organized materials, and visual highlighting of important aspects of a task or activity. Classroom modifications could also include providing a quiet area where an overstimulated child can go to calm down, having the child sit in the front of the class close to the teacher, and providing fidgets to stay focused on task. This would be a compensatory strategy because it adapts the classroom to fit the needs of the child and would include preparatory tasks to make learning easier.
Implementing social stories is another intervention to help improve behavior. The role of social story is to show proper behavior in the same context that it needs to be, since children with FAS have a hard time applying situations to other contexts. They can be used to illustrate proper ways to react in the classroom to something that may be bothering the client as found by the teacher in the chart. Overall, the goal of a social story is to increase the child's understanding of the situation, assess their comfort level to the situation, and suggest appropriate behavioral responses to the situation in the future. This type of intervention is remedial and preparatory as it aims to improve the child's skill in this area and gets them ready to engage in this task in the future.
Here are our references.